So imagine that you're living now in a house where you can't get out of the house because you can't get out of that body. You're feeling the pain. You tried for 20 years, you tried all kinds of treatments. The pain is spreading and the volume of the pain is turned up. No wonder they have depression, anxiety, they can't sleep, they can't concentrate. They call this the brain fog, fibro fog. These people that have this kind of nociplastic pain, they tell me, doctor, I cannot even read your book. I can't watch your videos. I can't exercise. I'm fatigued all the time. No wonder. It's like living in a house that the alarm is out of whack. You need to call the alarm company, not the electrician, not the fire department. They come, they will regulate the sensor.
Hello, this is Dr. Karmy for Chronic Pain Chronicles, and today with us we are lucky to have Dr. Andrea Furlan. She is both a physician and a researcher and an educator at the University of Toronto University Health Networks. And hello, Dr. Furlan.
Hey, hello, Dr. Karmy. It's a pleasure to be talking to you today and to your audience. Thank you so much for inviting me.
So I guess just in a way of a little bit of introduction, a lot of physicians I've interviewed came from other countries. We had someone from Italy, we had someone from Ireland, we had someone from Israel. So you also didn't start in Canada.
No.
Can you tell us a little bit about, how you started in medicine and maybe even how you got to Canada and maybe
Mhm.
even a few thoughts how the systems are different?
Yeah, so I did my medical school and residency in physical medicine rehabilitation in Brazil at the University of São Paulo. And right after I finished residency, I was married. My husband is a Brazilian, he's an engineer, and we didn't have kids. We were just, in our late 20s, and he had this idea to immigrate to Canada
Yeah.
because he was in the IT, information technology world. It was easy for him to apply to get a visa, and I came with him without having a medical license here. So I started doing research. We came to Canada in December 1997. So that's a long time ago. And then I had my kids here. My son and my daughter are Canadian. They're born here. And then I started doing research. I love research. In my early years, I did a lot of work with the Cochrane collaboration, doing Cochrane reviews, meta-analysis, writing guidelines. And it was in 2006 that I was offered a position at Toronto Rehabilitation Institute, UHN, to do a clinical fellowship. And then after that fellowship, I became an assistant professor with a medical license to practice physiatry in the pain clinic. And now I am full professor at the University of Toronto in the Division of Physiatry, Department of Medicine. So that was my career. I started with research, transitioned to clinical practice, but I never stopped doing research. Even after I got my medical license, I was still doing guidelines. I was the author of the first Canadian opioid guideline that was published in 2010. And then after that, because I was invited to talk about that guideline all over the country, from coast to coast in Canada, I noticed there was a really big gap in medical education. And I started implementing Project ECHO, which is a community of learners. We are funded by the Ontario Ministry of Health to teach primary care providers who are interested in chronic pain and opioids prescribing. So I've been doing Project ECHO for 11 years now. Every week I am in front of a Zoom like this one here that we are using today. It's not just me, it's my team, my interprofessional team. And we discuss cases of chronic pain and opioids presented by anyone who is in Ontario, like a healthcare professional. This is only for healthcare professionals. So we're trying to teach the medical professions how to diagnose pain properly, how to examine a patient and choose the appropriate interventions. I've been doing more education lately. And of course, I noticed that the general public also needed to learn. That's why I opened the YouTube channel in 2019. and wrote books, because I think it's important, this communication between healthcare professionals and people with chronic pain.
I guess just a couple of comments. One is it's actually not very easy for physicians, especially if they're trained outside of the US, to actually get Ontario license to practice medicine. So that was quite a brave move, let's just say. And guidelines, there's lots of different organizations putting out guidelines. Cochrane Review, which is actually a Canadian initiative, as far as I know, is one of the most respected. And the reason for that is, I think, at least in part, is because it's not partisan. Unlike some guidelines, which often are created by a journal that sort of has a specific view of the world and certain incentive to promote that particular treatment or that particular approach to things, because most of the physicians who submit to the journal, that is what they do for a living. Cochrane is sort of more of, at least in my mind, has always been a little bit more less prone to bias, just because they have a very rigorous way that they approach the data and how data should be analyzed.
Yeah,
Yes, yeah,
they're more
that's
neutral.
my
Not perfect, but they're more neutral.
Mhm. So usually I give Cochrane reviews more weight than reviews coming from other journals. Not that other journals are bad, but I think Cochrane reviews has one of the highest standards out there.
Yeah, you're right. Yeah, it's actually started in the United Kingdom.
Oh,
Cochrane,
okay.
Archie
Yeah.
Cochrane was a physician in the United Kingdom, and so it's in his honor, but it's an international organization. And Canada had many, many years of contributions because the government of Canada funded many groups. Now they don't fund anymore, so there are no groups in Canada anymore doing Cochrane reviews.
So let's move on to your role as an educator. And one of the things that maybe not all patients are aware of, or I think as practicing physicians we're very aware, is that not all types of pain are the same. First of all, obviously, there's acute pain and chronic pain, with chronic pain being defined essentially as pain that persists after all the tissues have already healed. Typically takes 2 to 3 months for tissues to heal. So if your pain is there after was 3 months, it's not going to heal any better with resting. It becomes a much more difficult problem to treat. But on top of it, there's more than one reason why the pain persists. And that is why there has been a classification for different types of chronic pain. Can you touch a little bit on that?
Yeah, you touched on a lot of terms here that people usually confuse, and even my colleague physicians, they don't have that clear in their mind. And I understand why, because there are, you can classify pain to acute and chronic, which is basically by time. But you also now can classify a primary and secondary pain. And that is the pain primarily in the pain system, or it's secondary to a condition, a disease. And now there are also mechanisms of pain, and this comes basically from neuroscience of pain. Because in the last, I would say, 30 years, I graduated from medical school 32 years ago, and at that time we didn't have the tools that we have today to study pain. And it's amazing, Dr. Karmy. I'm a pain specialist, so I go to all pain conferences, I read all the journals, I subscribe to pain, and I cannot keep up to date with everything that is being published trying to explain pain. It is exploding, this area of science. So I'll try to explain here the things that I understand. And I'd like to talk about the mechanisms of pain, because if you understand, and this could be acute and chronic. So the mechanisms are basically what is wrong, where is the problem? Because pain is pain. We all know what is pain. It's that unpleasant sensation. It's a sensation. It has to be unpleasant. That's the definition, because otherwise, if it doesn't affect the areas of the brain that are responsible for emotions, that's the limbic system, it's not unpleasant. So it has to be a sensation. Like vision is a sensation, but it's not unpleasant. You don't feel pain when you are seeing some things. But pain is like, could be a touch, it could be a prick, it could be a cut, it could be a too hot or too cold. We have sensors. We don't have sensors for pain in our body. We have sensors for danger. And when those sensations come to the brain and activate the limbic system, then the person will say, this is pain. So all pains are interpreted by the brain, and the brain gives a meaning. So the way that the mechanisms of pain go, like there are basically three mechanisms that your brain can sound the alarm. That's basically the same thing as an alarm of a house, the same thing. So if you have a house and you install an alarm system, you want that alarm system to alert you, to wake up you in the middle of the night, making noise that is unpleasant if there is something wrong with your house, right? So this could be a fire in the kitchen. So that's why you install smoke detectors in the kitchen. You don't detect a fire, you detect the smoke. So the smoke detectors will say, well, maybe there is a fire, and then signals, the alarm goes off, but then you need to do something. That information has to go to the alarm company, which is probably in downtown, where somewhere. The person there needs to see, okay, there is a signal coming from the kitchen and a signal coming from the smoke detector. Therefore, the alarm company will say, I think it is a fire in the kitchen, we'll send the fire truck to the house. So they send the fire trucks, the fire department, the ambulance, the police, because there was an interpretation. So that's when our pain system is functioning the way that it was designed to. It is supposed to alarm, so it's supposed to generate pain is in the brain again, so the brain will interpret the sensations, including the vision. If you look at your hand and your hand is not damaged, but there is some sensation coming from your hand, the brain has to interpret and say, what is going on? My hand is saying that it's not being burned, but I'm feeling burn here. So the brain gets confused. So the brain has to interpret. So if there is a fracture, if there is an appendicitis, if there is a toothache, an inflamed tooth, if there is a rheumatoid arthritis with an inflamed joint or a gout attack where you see that redness, so your brain will say, okay, this is acute pain, this is nociceptive. The name for this kind of pain is nociceptive, which means there is a damage, I can see the damage, I'm going to send the fire truck, the police, and the ambulance, and which means the orthopedic surgeon or the surgeon, or you would take an anti-inflammatory and your pain will stop. So that's nociceptive pain. We all know that kind of pain, right? We all know, we all had a toothache or something, right?
Yeah. So that sounds like mostly acute pain,
Yeah,
but not always.
not all, yeah. So because acute pain can also be different, doesn't need to be nociceptive. We'll get there. So the second mechanism that we can have to generate pain, again, think about the pain is generated in the brain. So the second mechanism is, let's go back to the alarm of the house. So let's say that there is a burglar, a thief that wants to enter your house, and they know that your house has an alarm. So they go and cut the wires. They cut the wires that communicate your house to the alarm company. And that will create a short circuit somewhere. Or imagine that you turn the switch, the light switch of your kitchen, and there is a short circuit between the electrical wires and the alarm company wires. And every time you turn the light of your kitchen on, activates the smoke detector and it calls the fire department. So there is a problem in the wires. And the alarm will sound, because if someone cuts the wires or if there's a short circuit, the alarm will sound of your house. Again, so you can have pain that is neuropathic. So neuropathic pain is if there is a short circuit somewhere in your body, if there is a damage to the wires, the nerves, the neurons that carry that information of sensation.
So now
And
we have Two types, nociceptive and neuropathic.
Yes, and you see the treatments are different, right? If your alarm of your house is going off because there is a short circuit, you're not going to call the fire department. You call the electrician.
Sure. So, but in your analogy, the alarm company is actually the brain, and the wires and the sensors is actually the nerves
Yeah,
that transmit the
yeah,
signal to the brain.
exactly, exactly. So
Yeah.
let's go to the third type of mechanism. That's one that I would say it's not new. We have this third mechanism for thousands of years, but it's just lately, in 2018, that the International Association for the Study of Pain coined a name, baptized this third mechanism with a name. It's called nociplastic. Some people call neuroplastic, but that's okay as long as you use the word plastic because it involves plasticity. And why it was only possible in 2018 is because now we have the tools to find where is the problem. So nociplastic pain is the third mechanism, which means there is no fire in the kitchen, there is no short circuit, is the alarm of the house that is malfunctioning. So you have to call the alarm company and say, the alarm is going off all the time. It's constant. This is the most common type of chronic pain, is nociplastic. So these are people who have pain. Think about fibromyalgia. So they have pain all the time. It's annoying, it's constant, it's everywhere. They tried everything for nociceptive pain. They tried everything for neuropathic pain. Of course, they didn't get better because that's the wrong treatment. So if you have an alarm of your house now that is going off all the time, let's say, how can you live in that house? You cannot even concentrate if the alarm is going, making noise all the time, all the rooms of the house. So now, if you go to the kitchen, it's the alarm of the kitchen. You go to the bedroom and it's the alarm of the bedroom. You go to the basement. There's no place in your house that you cannot listen to that noise, annoying. Not only that, but Dr. Karmy, we know that nociplastic pain, the volume of that sound is amplified. So imagine that you're living now in a house where you can't get out of the house because you can't get out of that body. You're feeling that pain. You tried for 20 years, you tried all kinds of treatments. The pain is spreading and the volume of the pain is turned up. No wonder they have depression, anxiety, they can't sleep, they can't concentrate. They call this the brain fog, fibrofog. These people that have this kind of nociplastic pain, they tell me, doctor, I cannot even read your book. I can't watch your videos. I can't exercise. I'm fatigued all the time. No wonder. It's like living in a house that the alarm is out of whack. You need to call the alarm company, not the electrician, not the fire department. They come, they will regulate the sensors. Sometimes it's the sensors that are oversensitive. The way I explain to my patients is, imagine a birthday cake that you have, a kid is turning one and you have only one candle. And when you light that candle, it calls the fire department and it makes a big noise. It damages your party. That's what's happening to you. And it's so rewarding because I can show to them, I put a little bit of pressure in their skin and they say, it hurts, it hurts. I say, yeah, that's because your sensors are super sensitive. Like they are sounding the alarm of pain with a tiny little pressure. We need to regulate the alarm system. So I call myself this specialist in the alarm system.
So that's the third type of chronic pain. Are there any others?
Yeah, so the ISP, the International Association for the Study of Pain, they say there is the nociceptive, neuropathic, nociplastic, and then pain of unknown origin. Like you can still, examine the patient and you don't find anything nociceptive, nothing neuropathic, nothing nociplastic, and then you say you have pain from unknown origin, which I always find some kind of mechanism, and actually I find mostly mixed kinds of pain. Sometimes a person has 1 and 3, 2 and 3, or all three.
What about internal organ pain? Which category does that fit into?
Yeah, so visceral pain can So inflammatory pain, if a viscera is inflamed, like an appendicitis, a cholecystitis, then you know it's nociceptive. But it's interesting that visceral pain, the way that the brain interprets, because the brain doesn't have a good localization of that pain, it's going to create referred pain. So anything, our skin is very mapped, is very well mapped in our brain. Like if I prick my skin anywhere, my face, my lips, my tongue, my hands, my brain will localize that very well. But anything that is under the skin, including muscles and tendons, including organs, viscera, is not well mapped in the brain. So we have a referred pain. Sometimes a person has appendicitis and they may feel pain in the shoulder or in the back. A person may have a heart attack. And I always joke, I say the heart is a muscle. And the person doesn't come to emergency and they say, I'm having pain right here in the medial wall of my heart or in the lateral wall of my heart. They usually say it's in my jaw, my back. But the problem is in the heart. But referred pain is usually at a distance. Even muscles. We know the trigger points in the muscles like trapezius, even though the problem is here in the top of the shoulder, the referred pain of that muscle will travel through up in the head. So, but it could be nociceptive. There is an injury there, like a trigger point, a tiny trigger point, like a nociceptive kind of pain that could be sensitizing and transforming into nociplastic. We need to remember that any pain that is nociceptive, neuropathic, can sensitize the pain system. And that's what you mentioned in the beginning. You said chronic pain is pain more than 3 months, 6 months. So that after the period that it was supposed to heal, and now it didn't heal. And now the pain is spreading an area, which means that now the pain is transforming from a nociceptive or neuropathic into a nociplastic pain. So we also have nociplastic pain in the bowels. That's called irritable bowel syndrome. We can have nociplastic pain in the bladder. That's called interstitial cystitis or chronic bladder pain, chronic painful bladder, chronic prostatitis. Like they go to 10 urologists and they have pain in the prostate. They tried all the treatments that you can imagine for nociceptive neuropathic pain, and the pain is still there, it's constant. It's an nociplastic pain in the prostate, in the bladder, it could be in the bowels. So viscera also can have nociplastic pain.
That was sort of I guess, my next comment I was going to make. Very often you see people with fibromyalgia that in addition to fibromyalgia will have irritable bowel syndrome, and maybe they'll even have interstitial cystitis,
Yeah.
so sometimes some pelvic pain.
Yeah.
And what I find personally, at least, is the treatment for internal organ pains tend to be more difficult than treatment for sensitization of muscles and
Yeah.
joints and outside things. Do you have any thoughts on treatment of internal organ pain as opposed to
I agree.
musculoskeletal system pain?
I agree. I agree. And I would say I don't get a lot of those internal organ pains in my clinic because I'm a physiatrist, so people tend to send to me more that are musculoskeletal or neurological conditions. So I see more people who have pain after a stroke, after spinal cord injury, after multiple sclerosis, or after fracture, and they are not progressing well, so they send to me, and then I say, well, the pain is now transforming into nociplastic. So I don't get referrals specifically for pelvic pain, but my patients complain of those. Like they have abdominal pain, they have cystitis, and then what I tell them is first make sure that there is no surgical, no treatable causes that is inflammatory. Like I don't want to miss like an inflammatory bowel disease, like Crohn's disease or ulcerative colitis. So make sure that you don't have those conditions. And then if that has been excluded, we can treat with the same way that we treat nociplastic pain from other origin, because the treatment is the same, is retraining the pain system. It is retraining that alarm, is fixing that alarm system that is triggering and amplifying things all the time. So it doesn't matter where the pain is, the treatment will be the same.
To make another comment, just from my general observation for doing this for over 20 years, I will often tell patients that, especially fibromyalgia patients, is that often they get diagnosed with serious medical conditions later than an average person. And the reason for that is that pain is the way that our body tells us that something is wrong. But often, if you have fibromyalgia and you're always in pain, often the family physician will dismiss the pain as just part of their fibromyalgia. So it's really, I think, difficult for them to have early diagnosis for serious medical conditions. I will actually typically sort of try to teach the patients to try to understand what's normal for them and what looks different. And, especially if the pain starts to have some additional non-pain symptoms, in particular, to perhaps, advocate for themselves a little bit more when they're talking to their family doctor. But in general, I do find patients with fibromyalgia get diagnosed later than patients without fibromyalgia.
You're totally right. Yes, I also have that concern that I, Dr. Karmy, this is so important what you just said. So important because I think the patients, for them, pain is pain. And for them, it's hard to differentiate where the pain is coming from. So it is our obligation. We as doctors, we need to make sure we examine the patients. We are, doing the physical exams like family doctors. You cannot just dismiss them if they come 5 years later and say, oh, this is all fibromyalgia. No, you need to do your due diligence. You need to do your physical exam. You need to order your labs, make sure that you are excluding because they may have something new that is happening. They need to be investigated, not every time that they show up with pain. And also, I think that's really important that the patients receive education about fibromyalgia. What is fibromyalgia? Because they can help themselves. They can say, okay, I had a flare of pain in my back, but it's related to, I had a fight with my husband last night and now I'm super stressed. I didn't sleep well last night. So I'll try to relax today, calm down my pain system, which is regulating my alarm, see if this goes away. And if it doesn't go away, then go to your doctor. Maybe you develop something new, like could be an inflammatory arthritis, could be ankylosing spondylitis, could be lupus, it could be something else. But I think we need to educate the patients that those other diseases like lupus, rheumatoid arthritis, ankylosing spondylitis, or something else, they have other signs. And I like when I am examining my patients, every single thing that I do, I talk a lot during my physical exam because I'm telling them, I say, I'm looking for signs of lupus. Oh, I didn't find anything. Oh, I'm looking for signs of a neuropathy. Oh, I didn't find anything. So I'm reassuring them, I'm looking for this and I didn't find. I'm looking for this and I didn't find. I did this test in your shoulder and I didn't find any signs of impingement. So then they know in my head, I'm excluding things. I'm not just touching them because I want to torture them. So I
Yes.
think it's important for the patients to know we are doing our due diligence. I put my hands on my patients. A lot of physicians these days, they don't touch their patients anymore. All they do is order MRIs. And they
Yep.
say, you can't diagnose on an MRI.
But the other thing I will often tell patients, because they know pain, obviously everybody's pain fluctuates up and down day to day, month to month, based on a million different things that seem to impact it. Nobody's pain is stable. But usually after a while, people know what their normal is, what are their normal fluctuations in pain. So one of the things I'll usually tell them when they sort of are, worried about a particular flare-up of pain is, have you had this kind of pain before? And this is something you had for the past 5, 6 years on and off. Chances of it being something life-threatening becomes a lot lower than this is something you're experiencing for the first time. People often say, yes, I had pains before, but this feels different. So that's the types of pains that I think, are more worth investigating because it's very hard to give them hard and fast rule. You don't want them in the emergency department every day because they have pain and they're worried. But at the same time, you don't want the delayed diagnosis. So, the closest I come to is to say, is this something you've ever experienced before? Or is this something that feels like it's new and different? But
Absolutely. Yeah,
in
so
any case,
important.
so we talked about different types of pain. So then the question is, well, how often do these types of pain occur? So we've got the nociceptive, we got nociplastic, we got neuropathic, and then we got pain of unknown origin. So is there any research on that?
There are, and it really depends on where you do the research. If you go to my clinic, probably you will see a lot of nociplastic pain there, but that's because a lot of people refer that kind of pain to me. It's not because it's the most common type. If you go to a different clinic, like a physiotherapy clinic in the community, maybe they see more nociceptive because people seek them first. So it really, we don't know the statistics globally, like I say, which one is more common, because it really depends where you are collecting that data. But in all the pain clinics and among the chronic people, like chronic pain population, and there is even neuroscience, because Dr. Karmy, if you had been following the new advances of functional MRI of
Mhm.
the brain, it's amazing. I love, it's so hard to understand those studies, those papers, but it's so amazing. Because a functional MRI is an MRI of the brain and the brain stem or the spinal cord, but it's different from a picture. It's different from that MRI that we do like black and white. That MRI from like the spine or the brain, black and white and gray that we see, it's a picture of the brain. A functional MRI is in color and it's like a video. So it's a video of your brain. It is like how it is functioning. It shows you which areas are light up, which areas are connected. We can see connections between neurons. It's amazing. And now that they are having these tools more in more laboratories in the world, they are seeing that most people with chronic pain, like pain that is lasting beyond that period of acute pain that you would expect the tissues to resolve, are 100% nociplastic, because in the brain you can see the areas of nociceptive would be more the thalamus. I think it's the posterior insula that activates when you have acute pain. You see the somatosensory cortex, which is the localization of pain. And in chronic pain, you don't see those areas activated. You see the limbic system. You see the anterior insula, which is responsible for the emotional aspect of the pain, the unpleasantness. You see the amygdala light up. You see the areas of the brain that are more, they look more like depression. So the brain of a person with chronic pain has more similarities with a person that is suffering from chronic major depression than a person that is having acute pain. They're very different. The computer can tell if the person is in acute pain or chronic pain because it's so obvious in the functional MRI.
Now,
So
just
we
to
know, yeah, so that's why the treatments that we use for acute pain, they don't work for chronic pain.
So just to clarify, obviously nociceptive pain can also be chronic if
Yeah.
there's a disc compressing, say, a nerve or osteoarthritis of the knee. So there can be chronic nociceptive pain. But there's also chronic nociplastic pain or even chronic neuropathic pain. So, what you are saying, the studies where they just looking at patients with nociplastic pain when they did this functional MRI, or they just took all patients
So
with all types of chronic
mm,
pain and that's what they saw.
amazing question. So the first studies, they took a look at chronic back pain. So that was I think the first studies that we saw published on this were 2004. So we know this since for more than 20 years. And Dr. Vanya Apikarian from Chicago, he's the pioneer of doing this. And in the beginning, he was doing only with chronic back pain. Now we have studies for everything: complex regional pain syndrome, arthritis, migraines, irritable bowel syndrome. Yes, so the computer can distinguish, like just by imaging, if this person is having osteoarthritis, CRPS, or back pain, for you to have an idea. And this is computer machine learning, like they need a lot of data, right? It's also interesting that we are not using those images to make the diagnosis yet.
My opinion is that although on average, the patterns can be used to separate people in pain, people without pain, people with different types of pain. You need an average of a very large number of people. If you look at any one individual person, then it sort of falls apart. In other words, there's a mean and then there's a standard deviation in terms of how far people are from the average. And in this particular case, a lot of people can be very far from the
Yep,
average.
you're totally right. That's the reason we don't use functional MRI, because the person may be having pain. If they say they're in pain, their pain is real, and the functional MRI doesn't show anything, and then they will be labeled as malinger or lying or liars. So that's because of ethical reasons. In the studies, we use the average, but we don't want to make a false accusation that, oh, your functional MRI is not showing anything, therefore you are lying. That would be a terrible use of functional MRI, which is possible because the brain may not show those images because the computer cannot detect everything. But if the person is saying they're in pain, you should believe what they're saying.
So I guess part of the reason is functional MRI is just not good enough to use as a diagnostic tool. It's good enough to
Yeah,
use as a research tool, but not as a diagnostic tool. If it had
completely. Yeah,
99% accuracy, we would be using it.
yeah, yeah. I think that's the next question people ask me. Why don't you do a brain image of my brain and tell me what kind of pain I have? It's because, can I tell you a story that I think it will illustrate really well why we are not doing this? You probably know in 1998, there was a report in the BMJ in the UK. So a doctor wrote this case report. And what happened was there was this construction worker, 28 years old, I think. He was working construction, wearing his boots, and then suddenly he stepped on a nail, you know, those long nails, like 10 inches. I don't know how many inches, but very long. So he stepped on the nail, it transgressed his boot, and he looked at his foot and he could see the tip of the nail sticking out on the top of his boot. He started screaming. His colleagues tried to remove the nail, but every time they tried to remove the nail, he screamed. So they took him to emergency. So the emergency doctor is the one who published the case. And they had to give him fentanyl intravenously and midazolam. So fentanyl to remove his pain and midazolam to sedate him so they could remove. So they removed the nail and then they removed the boot, and there was no injury to his skin. The nail had passed between the toes. Okay.
Mhm.
No, no, not
No
even a
tissue
scratch
injury,
on,
no tissue injury at all.
no tissue injury at all. So this was a classical example of acute nociplastic pain. Because first of all, I have patients who criticize me or they write comments on my social media posts saying that I'm crazy. And I'm telling that the pain is not real. I'm telling them that the pain is imaginary. I say, no, 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 nociplastic pain is very real. Who is going to say that that construction worker did not have real pain? He had real pain because his brain saw. That's what I'm saying. The brain is always integrating the sensations. The brain, the vision saw the nail. His skin probably noticed, you know, there was a touch sensation. So the skin probably noticed that something was there. So he got sensations from the skin. He got his vision. He got his colleagues around him screaming. So he had some auditory feedback. So vision, sound, sensation, So when the brain integrated all of those sensations, sounded the alarm of pain.
So it's
That was acute
fundamentally
nociplastic pain.
brain is guessing at things.
Always. So that's the message. The brain is always guessing if there is a danger or not. And if the brain decides that there is a danger, it will sound the alarm. And if you don't do anything about that alarm, it will amplify. It will make the alarm louder and louder and louder and louder. That's central sensitization.
So let's maybe, I guess, to the crux of the matter. And that is we have all these different types of chronic pain, and patients will often go to pain clinics where things get done to them. Where, like in my case, you know, my type of clinic, we do a lot of treatment of patients with nociplastic pain with things like nerve blocks, trigger point injections, etc. But there's on top of it, often that's not sufficient. It might move the needle in the right direction, but I find in general it is not sufficient to really give people high quality of life where they really able to do what they want to do. So, you know, I think a lot of the focus is on what can patients do themselves to make their life better, make their pain less severe. And that goes back to things like lifestyle interventions. That goes back to mind over matter approaches. Even go to things like exercise, and then goes back to maybe even supplements. And then, of course, which it sounds like you're telling me is that depending on what type of pain you have, these lifestyle approaches will differ. So, do you have any sort of takeaways, any insights that you can share?
Yes, absolutely. I have. This is what I spend most of my time doing. I would say those nerve blocks, injections, I also indicate, and many of my patients, I send them to my colleagues who do interventional. If I identify a nociceptive or neuropathic pain, they are great. As I said to you, many patients have mixed pain. But for nociplastic pain, the treatment is completely different. It's completely different. You need to think again about the mechanism. Why is the brain sounding the alarm when there is, no danger in the body? There's no short circuit and no damage. So the approach we use is first diagnose that this is the kind of pain. So say you have nociplastic pain. You do. I have no doubt that you do. So even though the pain is coming from this region of your body, the damage is not there. Your brain still thinks that is damaged because there was a memory of pain there, but let's stop focusing there. We now need to think about how can we calm down this alarm? So how can we retrain your alarm system to stop sounding the alarm? So the first session that we spent with them, we explain the neuroscience of pain. We give them like these examples that I gave to you, the alarm, the candle that lights up the alarm and that calls the ambulance, the fire truck. So they understand, okay, so, a person with fibromyalgia or a person with CRPS or a person that has chronic back pain, but they're not responding to blocks anymore. They're not responding to neuropathic pain medications. It's because their pain now is nociplastic. So you need to stop focusing treatments in that area. So you need to say, enough. I'm not going to do more injections. I'm not going to do more blocks. We're going to stop doing things there. We are going to retrain your pain system to understand. You're going to convince your brain that that area of your body is strong, it's healthy, can move normal. You can do anything you want. You can dance, you can swim, because I examined you. You don't have any damage there because they're afraid to move. Like for 20 years, they were told, don't move the lower back. You're going to damage more. Now for them to unlearn and redo, this is all synapses, Dr. Karmy. We are using neuroplasticity. That's why the name is plastic, because if the brain created those synapses to protect you, like it's not your fault. The brain just created those synapses and sounded the alarm to overprotect it. Now we need to create new synapses here to say your brain, you're safe. You can actually do anything you want. There's no restriction. Dr. Karmy, I never had so many good results in my pain clinic than after I started approaching nociplastic pain this way. I have patients that with a few sessions, they ask me, but doctor, I was told that I could not do anything. I said, no, you have. You have my permission. You can do anything. What do you want to do? I want to dance. I said, okay, you're going to write here. When you're going to dance, how many times? They come back to me, Dr. Karmy, and they say, what a difference. Now they started moving again. So now, what a transformation, Dr. Karmy. Now these patients, they come back to me and they say, I'm moving again, I'm living again, and I'm taking care of myself. I know what to do. So now they understand the principles of nociplastic pain is basically to calm down that nervous system that was amplifying pain, that was central sensitization, to retrain everything. So activating the vagus nerve is essential. A good night of sleep is essential. I teach them how to open the brain's inner pharmacy. I say, you have a powerful pharmacy inside of your brain. Let's open that one. You need to release those endorphins, serotonin. You need to release that dopamine, endocannabinoids. You can produce your own endocannabinoids. So, and how do you do this? Is with healthy lifestyle, as you said. Keep moving, start moving again, sleep, a nutritional diet, lose some weight if you're overweight, quit smoking, reduce alcohol, because alcohol and smoke are terrible for your pain system, and work on your emotions, because a lot of our brain will sound the alarm of danger because we are stressed. If you're hyper vigilant all the time, then your brain is going to sound the alarm. Also, if you carry traumas, PTSD, or adverse childhood experiences, this means that your brain, when you were growing up, was used to stress, like a child that grew up in an adverse childhood environment. They trained their brain to detect danger. That's how they did. That's how they survived. It's a survival mechanism. So now they are an adult that is looking for danger everywhere and trying to overprotect you. Guess what the brain is going to do? With a minimal sign of danger, woof, it's going to sound the alarm. So that alarm could be a tachycardia, like a heartbeat. It could be a fainting episode. It could be a panic attack, but it could also be a pain in the neck, a pain in the back, a pain in your shoulder, pain here. So the brain will try to talk to you to tell you, slow down, calm down, take care of yourself. And it may use the pain as a language to talk to you.
Dr. Furlan also has a lot more ideas and details about this topic. She's written several books, and she has a very popular YouTube channel that provides a lot more information about this. Thank you, Dr. Furlan, for joining us on the podcast.
Thank you so much, Dr. Karmy. As you see, this is my favorite topic to talk. I could be talking to you forever and ever, but I wish your audience the best. And I hope that this information will help them to understand better what's going on in their bodies. Thank you so much for the work that you do in disseminating all this knowledge.
Thank you. So, what are my final thoughts? Well, first of all, I wanted to clarify a couple of things. Dr. Andrea Furlan is an academic pain physician, and in the context of academic pain centers, high frequency nerve blocks are not used. Typically, in academic centers, nerve blocks are used for compressed nerves or inflamed joints, so they're primarily used for nociceptive pain. Typically, the injection is performed with X-ray or ultrasound guidance, and typically the injection is performed only once. If the treatment is repeated. It is typically repeated in 3 to 6 months, or sometimes nerve blocks are just used diagnostically to figure out if a nerve is a source of the pain, followed by destruction of this nerve with radiofrequency ablation. This is in contrast with high-frequency nerve block system as practiced in the community setting. High-frequency nerve blocks done on weekly basis are actually used to reduce peripheral and central sensitization or nociplastic pain. High-frequency nerve blocks actually work in a complementary fashion to mind over matter techniques. Nerve blocks are trying to reduce the pain signals that are bombarding the brain and causing these anatomical changes in synapses and sensitization, whereas mind over matter approaches are trying to separate the pain signal that the brain receives from the anxiety response that these signals generate, which actually make the pain the unpleasant sensation. Both of these approaches can be helpful, and both of these approaches can change or reverse the anatomical changes in the brain. However, depending on a patient, some respond only to nerve blocks and have no response to mind over matter approaches. Some respond only to mind over matter approaches and have no response to nerve blocks. And then there's the group that have a partial response to each. So my typical advice to patients when I see them is not to dump approaches which through trial and error they found useful in the past before adding a new approach, but rather layering on new approaches onto the old approaches which they found helpful over time. Obviously, if the old approaches did not help the patients at all, then those approaches can be stopped. In the unlikely event of the new approach being so far superior to the old approaches that the pain almost completely goes away, then of course they're welcome to get rid of everything and just stick to the approach which works the best. But the most common situation is that patients with nociplastic chronic pain use a combination of different approaches to improve. Also, I do not want to leave you with the impression that if you just tell yourself that you have no pain and start doing all the physical activities you used to do before the pain started, you will have a good outcome. The point is that nociplastic pain is not a pain you are imagining. It is a pain caused by anatomical changes in how different nerves are wired up together. And if you just go back to doing activities you used to do before the pain started, you will have a very severe flare-up of pain, which could last weeks. A more realistic approach is to just start with very light activities and light exercise, and then gradually increase it by 10% every couple of weeks, as long as you don't get a flare-up after the activity. So while in the long run, setting a goal to participate in certain activity is reasonable, the short-term goals should be realistic and based on your current activity levels. It is a slow progression, kind of like training for a marathon, rather than just waking up one day and saying to yourself, yes, I can run a marathon today without any prior training. So to sum up, I think that Dr. Furlan created a very valuable body of information on how you can take charge of your pain. And I would encourage you to look at her YouTube channel and perhaps look at some of the books that she has published. She's also a practicing physician, so if some of these approaches resonate with you, you can also ask your family doctor to refer you to her for an assessment. I do not know whether or not these approaches will work for you, but they have no risk, and therefore, in my mind, they're worth a try. Thank you.
Disclaimer: when it comes to your health, always consult with your own physician or healthcare provider for personalized advice and guidance. The information provided in this podcast is for educational and informational purposes only and should not be considered medical advice or a substitute for professional medical care.